I heard I've actually heard multiple people say that artificial intelligence or AI is not going to take your job. Someone who knows how to use AI is going to take your job. And I would say the same thing to those folks that you're describing, like, hey, it's highly unlikely actually that any technology can do the job of the office manager. That's someone who makes the place run. And AI will never be able to call up a receptionist who's having trouble making it to work on time and trying to understand why that is. They're not going to be able to AI is not going to calm down an upset patient because you're running late. There are things that we need humans to do. And so I'd say my suggestion is, hey, you need to be as up to date and leverage all the tools that are available to help you with parts of your job that you don't actually need to do. So if you're making the schedule for the physicians for an on-call schedule, for example, there's pretty good technology that does that now, that knows that Dr. Smith doesn't like to be on Fridays, but really doesn't mind Saturdays and Sundays, and that Dr. Jones is taking vacation during this month. Like, all of that information is that trying to kind of come up with the sweet schedule, that is not something that a human should be doing now. And so
nothing in this podcast is intended to render legal, financial, medical, or other professional information. Because the details of your situation are fact-dependent, we highly encourage you to find a recommended individual that you can trust to give you the expertise that you need related to your situation.
This is Concierge Medicine Today's DocPreneur Leadership Podcast. And today we have Dr. Craig Joseph. He is Chief Medical Officer at Nordic Global. He's got great glasses and gets his style, I'm told, from his wife and the salesperson, like we all do. So, Dr. Joseph, thank you for being with us today.
It's my pleasure to be here. I am known for having good people around me to help me select glasses, and everything else I'm not that good at, but they let me keep doing it. So, pleasure to be here.
Well, having good people around you is so important, and especially in healthcare, because, everything is on your shoulders as a physician. You're expected, when you get kicked out of medical school in a good way, finally get that degree and you've paid your dues and starting to pay off that debt, everything is on your shoulders. You're expected to be everything for everybody, make no money like it's a badge of honor, and then also stay in business. And so you got to stay in business by surrounding yourself with good people. So we're going to talk with Dr. Joseph today about a lot of different things, but he's also got a book out, and the book is called Designing for Health and a Human-Centered Approach. And he's going to talk a little bit more about that, but his background, I'm going to let him dive in, is a little bit in primary care pediatrics, and then he made the move to tech. And we're going to undo some myths in healthcare and uncover what he's working on and what the future of healthcare delivery looks like, which is that's on the crystal ball and the magic 8 ball for everybody. So go ahead and tell us about what drew your interest in healthcare. Was it family business? Was it, I was done wrong? What's your story?
Now I've got to come up with something good. I was done wrong, and then I wanted to go to medical school. I don't think I have a very good story. I don't have I don't have physicians. I had a dentist. I had an uncle who was a dentist, but just always had wanted to go to medical school. In undergrad, I majored in computer science, which was very unusual in the late 80s. I don't think it's that unusual now, but I'm old. And in the late 80s, I was a CS major and pre-med. And so that kind of helped me stand out for medical school. Most folks are biology or chemistry or something like that. And so got into medical school. The intent, at least for me, was to become an emergency medicine physician. I was an emergency medicine medical technician and EMT in undergrad, really enjoyed that. And then I spent some time in the emergency room, and things changed. I decided I didn't like being bored most of the time and then trying to prevent people from dying a small percentage of the time. And really started to look for that. What could I do that gave me a longitudinal view of my patients, and just fell in love with pediatrics, mostly just the patients. I love kids. I love working with them. I love their brute their brutal honesty. They will tell you if you're looking in their ears and you have coffee breath, they will tell you that. And I loved it. And so practiced primary care pediatrics for about 9 years, and then started looking for ways I could combine that tech background that I got from undergrad with the clinical practice that I had done for a while, and made the move to go and work for an electronic health record vendor. Was there for about 7 years, and then really kind of branched out and started working more on the hospital side. Became the chief medical information officer for a number of hospitals, and that was fun. And now I've been doing consulting for almost 4 years now, and so that is my story. And as you mentioned, I co-authored a book called Designing for Health: The Human-Centered Approach. And that was based on the fact that all these hospitals and healthcare systems around the country, and a little bit in Europe as well, that I visited and helped, seem to be making the same mistakes over and over. And so, the basic mistake was ignoring the way humans are wired, and trying to make it, wondering why can't we get those physicians and nurses to do what we think they're supposed to do? And then when you actually looked at the workflows or looked at the tools that you gave them, you said, I came to the conclusion, wow, you made it difficult to do the thing you want them to do. And then you wonder why they're not doing it. So,
yeah. And then you back that up with the 13 other items and people and, moments I had before I finally got to the waiting room. And, you're spitting out incredible knowledge and information in the exam room to the patient, but yet they're thinking about, the person who made them complete the forms again at the front office and didn't smile or even look up and was like, do you even have an appointment today? And how they greeted them. And it's a distraction. And so then they come back 3-6 months later and it's like, you didn't do any of the things I told you to do. But before we jump into the book and what your work is doing at Nordic, speaking to those who are listening, our physicians who may have an entrepreneurial tendency, but are so busy, so hesitant to pull that thread. And, they've been given opportunities to work on boards or express their business views in certain circles. What finally was the moment that you said, I've got a real, we interviewed one doctor and he said, I was told, hey, you're a great doctor, but you would be really effective in business. What was one of those conversations that came to mind for you that made you kind of pivot from primary care pediatrics into the business side of things?
Yeah, it's going to sound weird, but I had a day off. I think a lot of us have days off, and I'm one of those people that's just not good with a day off. Like I need to be scheduled, or I'm going to be bored within 2 hours. And so I was looking for something to do on my day off. Sometimes I went and helped out other offices or friends of mine from residency, and worked in their office seeing some overflow patients. But ultimately I went and found an hourly job once a week or so, working for a quality improvement organization. And what they did was they were responsible for the Medicaid population, for approving. They were responsible for many things, but among those things was approving the procedures. And so if a patient who had Medicaid needed to have a hysterectomy, the physician would submit the necessary information, and if the documentation supported the procedure based on standards, a nurse approved it. And so the nurse would just look through the paper. There was so much paper. Would look through the paper chart and say, yes, this patient meets the criteria, it gets approved. However, if it didn't meet the criteria, either that it was missing or specifically contraindicated, then that got escalated to a physician. And as I mentioned, I'm a pediatrician, and yet I was being asked to make decisions on the ability, the ability for an obstetrician gynecologist to do a hysterectomy. And it was eye-opening to me, because oftentimes I could just interpret information that the nurse wasn't allowed to interpret and then just approve it based on the criteria. But sometimes I had to call the physician, and I would always start off with, "Hey, I'm a pediatrician, but I'm here to help you. I'm not incentivized to tell you that you can't do it. I just need to understand the criteria, understand how what your medical decision making was." And it was actually a joy, because I wasn't in a difficult position with these docs, and I wasn't working for some evil insurance company. Or at least that was the perception, and that was my perception as well. And it just kind of opened my eyes to other opportunities that you could use. Use your clinical experience, use your kind of worldly experience that you had outside of medical school and residency, and help people. I was in that case, I thought I was helping patients. I thought I was helping doctors. I thought I was helping the state, to make sure that quality medicine was being provided and offered to the patients, and kind of opened my eyes and said, there are other things that I can do that are clinically relevant, that depend on my on my clinical experience, and can really help a lot of people, more so than the 20 or 30 or 35 patients that I could see in a typical day.
So there's so much to unpack, and I want to talk about your book first. Let's talk about the book. Have you written more than one book? I think
just one that I know of.
I know. I was talking with another author, because I write books myself, and I was talking with another author, and he's like, if you get to a level where you're super popular, AI will start writing books with your name, and that's a little bit scary too. Now there's, I don't know how that happens. Probably some like those texts that magically say we have a postal service package that we haven't picked up yet. So not sure how that all happens, but tell us a little bit about your book, because I think human-centered design is, in taking an approach with that, especially when you work in technology, the challenge right now, it seems, for most physicians as they look towards the future and as they educate the younger generation of physicians is, how do we not compromise on quality, stay personal, get all the information we need necessary to the patient, but do it in a delivery model that Gen Y and Gen Z and others want.
Yeah. My interest in design, and when I say design, I don't mean picking out glasses or clothing, but creating things, be they medical instruments or technology or specific workflows, or even buildings and rooms. Imagine clinic rooms too. It all started with this guy named Don Norman, who wrote a book called The Philosophy of Everyday Things. And that's turned into The Design of Everyday Things. And he's written a number of other books, but he starts off looking at a door and showing how doors can be poorly designed. And once you read this chapter of his book, your life is inexorably changed, because you can't look at a door again. And he talks about, when I mention the design of a door, I'm talking about how do you use the door? How do you open the door? Do you see a handle? What are you supposed to do with the handle? No one ever taught you in school what you're supposed to do with a handle. No one ever taught you in school what you're supposed to do if there's just a flat metal, aspect to the door. But I know, and I think everyone that's listening knows, well, if you see a door handle, you probably should pull on that door is going to open towards you. And if you see a flat metal bar, you're probably going to push on that, because there's absolutely nothing else you can do. You can't grab and pull it towards you. It's impossible. You have to push. And so often, and you'll see it today if you go out and look around, it might be in your office right now, you'll see a door that has a little sticky note on it that says push or pull. Or you'll watch people go and do the wrong thing and look frustrated and then do the right thing. And that concept that, boy, even a door, even today, is not well designed. People haven't thought this through. And it's not like folks haven't figured out how to use the door. It's just that it really gets frustrating when half the time you go to the door, it doesn't work well. You're pushing when you're supposed to pull. It's kind of like putting in a USB, the
Oh my
current,
goodness. Yes.
right? Yeah, it's a 50-50. You got 50-50 odds if you're going to put that USB-A in correctly or not. The newer ones, they don't have that problem. They're better designed. And so kind of taking that principle of human-centered design of how people actually think and work, and then leveraging that and pushing that into kind of healthcare. So, we have a chapter, my co-author and I have a chapter called Getting Rid of Stupid Stuff. And that's not my term. That was a term that was in an article, a very commonly referenced article in the New England Journal of Medicine, whereupon a chief medical information officer in Hawaii, at Hawaii Pacific Health, simply asked people, what are things that you think are stupid or don't make any sense in the technology that we offer you at our healthcare system? And I don't think that's that uncommon. People have asked, surveyed doctors and nurses. What's uncommon, though, is that she did something with those results, right? Oftentimes you complain about something or someone asks you a question and it goes into this black hole. You never hear back. Well, she actually made changes, and some of those were minor changes. And so I'll give you one example. A nurse had complained that the electronic health record that they used required her to document the state of the umbilical stump for a baby up to 6 months of age. Now, I'm a pediatrician, we talk about the umbilical stump in the first week or two. Sometimes it's oozy, sometimes, we have to clean it up. We want to make sure it doesn't get infected. Those are good questions to ask, maybe till the child's 2 weeks old. After that, we don't really care about your belly button very much. And we figure if something's happening, you're going to tell us about it. Yet the EHR was requiring her to comment on the belly button until the child was like 6 months old. It was clearly an oversight. There was nothing there. Now, did that ruin her day every day? No. It was just a few clicks. It's just a few seconds. But there's this sort of kind of one of the terms coming out now, the moral injury, this idea that, oh my God, I am wasting even a second of my time on these stupid questions and no one's interested in fixing them. So, asking folks, what do we have you do that doesn't make any sense? Sometimes people say, well, it doesn't make any sense that you want me to jump through this hoop. Sometimes it does, actually. So, sometimes there's a law or a regulation that we might not agree with, but it's there and it requires being dealt with. And so sometimes it's educating folks and telling them, actually, there's a reason for that. Sometimes it's, I didn't realize you're using these data for some research project or some report that's actually very helpful to me and my patients 2 years from now when they turn 2, right? And so, kind of giving physicians and nurses that information is very helpful, kind of being transparent, which is another chapter in the book. So these aren't really concepts that people don't understand. It's just that they don't leverage them in an intentional way, and kind of stuff gets away from us.
And what's the name of the book and where can we find it?
Yeah, Designing for Health: The Human-Centered Approach. It's available on Amazon. It's available at most booksellers. Like I mentioned, I co-wrote it with a colleague of mine, Jerome Pagani. He's got the PhD, I've got the MD. I tell everyone that I'm good looking and he's smart. And together I'm not really good looking for those of you who are listening. Together we put I think we have a nice kind of somewhat evidence-based, definitely clinically based book together that's entertaining and there's no brilliant ahas here. It's all just kind of like, yeah, we should be doing this. Why are we not doing this? And so hopefully people who read it are armed with some evidence or some talking points that they can use for their own clinics, or if they're working with a healthcare system to help make things better for not just for the clinicians, but for patients and the operations folks and everyone involved in healthcare.
Well, our guest today is Dr. Joseph. We'll put the links on how to access the book, and you can go, we'll put that in the show notes below, as well as his background and how to connect with what he's doing. You touched on something there, people in healthcare interested in fixing things. I was just having a conversation yesterday with a former insurance executive who used to work for some of the the big payers out there. And what was interesting is, the same conversation, same threads that you're pulling today as well. You know, there are people in healthcare, even at those places, even in EHR, even in technology, who are trying to fix things. Like, it's not all speed bumps all the time, even though it really truly feels like that, especially from maybe where your seat on the bus is today. So I want to talk a little bit about another big picture topic, because we like to solve all the world's problems of healthcare here. How do you improve healthcare for doctors and patients and make it easier to do the right thing?
Yeah. So, sometimes it's, as I mentioned, kind of that gross concept, getting rid of stupid stuff. Sometimes making it easy to do the right thing. The hardest part almost always is not the technology or the workflows or things like that. It's deciding what the right thing is. I can't tell you how often I've been working with, healthcare systems and hospitals. And I always say the same thing, whether I worked for an EHR vendor or doing the consulting work I do now. My job is to make it easy to do the right thing. Your job, chief medical officer or clinical quality committee, is to tell me what the right thing is. And so if the right thing is, hey, these are the 2 antibiotics that we find most effective for community-acquired pneumonia in our area at our hospital, and we wish doctors would use that one of these 2 antibiotics, unless they had a reason for not using it. Oh, the patient's allergic. Oh, the patient was already on an oral form of this, and changing them to IV might not really be that effective. Then that makes sense. So we don't want to make it impossible for them to order something other than these 2 antibiotics. Well, how do you make that easy to do the right thing? Well, first of all, you make sure they're in an order set. You make sure that that order set is easily found. You make sure that one of them is defaulted in, right? You really want to make it easy for me to do the right thing. When I open up that order set for community-acquired pneumonia patients on admission, I should have an antibiotic that's already pre-checked, and one that's kind of approved by your ID committee, so that we know it's a reasonable antibiotic and it works most of the time in our area. That just one example. And again, oftentimes I see that that's not done. There's no default selected in the EHR. It's doctors might say, well, that's only 70 or 80% of the time what I need. There's 20 or 30% of the time I need something else. Okay, well then you'll click something else. That's one click. That's fine. But let's make it easy to do the right thing. Most of the time, this is the right thing. And so I think job number 1 is agreeing, which physicians are really difficult. We have a hard time agreeing on what the right thing is. But when we can agree on that, let's make it easy to do that. Just jumping through, another hoop. If we want patients to fill out information on the patient portal so that we can collect demographic, collect insurance, collect information about the history of present illness for today, so that it's already there and we don't have to waste their time and ours with having a nurse or a medical assistant or having us collect that information. That's fine. Let's try to make that easy for them to do. Is it phone friendly? Do they have to remember a username and password, or can we just send them a link? Are there easier ways? And then when they take the time to fill out the information, the worst thing we could possibly do, which my physicians regularly do, is act like they never did that work. Oh, so what brings you in? What I want to say is, dude, I spent 15 minutes filling out all this stuff.
Yeah.
Why are you acting like I didn't fill it out or you didn't read it? And the answer is because he didn't read it. And so that does not incentivize me to do the right thing next time. Well, I might get the link. I might, be asked to fill out this information. I'm like, if you're going to ask me again when I get there, it probably doesn't make sense for me to put in 15 minutes. And that's not a lot of time, but it's time. It's time I'd rather be doing something else. And so, make it easy for me to do it. That's great. But then you got to leverage that information. And it's a completely different experience, as you mentioned, when the doctor opens the door to the exam room and says, hey, Craig, I see that you've got this concern and that you've tried this and that the pain is 4 out of 5, and that you followed up with this other physician and it's not getting better. Did I get all that right? Wow. That's a completely different story and a much better experience for me, and incentivizes me to help you by filling out all that information ahead of time the next time.
Well, and there was something that Steve Jobs said. He said, you've got to start with the customer experience and work back toward the technology, not the other way around. And you know, what, I walked into a pediatric office recently within the last year. And the first thing I'm bump into, and the first thing that catches my eye, 16 clipboards
Yeah.
at the ready with the chain attached to the pencil, to the pen, like, I don't want your pens, but I get it, right? It makes it more convenient for the staff to not have to search for pens. But what actually happens with the 14 pages I just completed as a patient, and I give back to the staff, and then I wait some more? What happens with that stuff?
Well, I mean, I think typically it'll get, if there's an electronic health record, it gets scanned in. And then it might get perused by the physician. And then it just goes somewhere. Whether you still have paper charts, it'll sit in that paper chart. But it's not, to your point, it's not going to be leveraged, because next time you come in, what are you doing? Filling the same thing out. And the goal is simply for an established patient, at least my goal as an established patient would be, hey, tell us what's changed. That's all I really want to know, because we've already established my past medical history. You've got my labs. You should have that. What's changed? Oh, this other doctor ordered some labs. I want to make sure that you see those because you didn't order them. Had this x-ray that you told me to do. I went to see the specialist. I hope he sent you a referral phone, a referral letter so that you know what he told me. That's the kind of information that's actually helpful, and patients don't mind giving that up, but they certainly mind, as you do, appropriately so, answering the same questions over and over and over again. And again, let me be clear. I totally understand why 18 people ask you what you're allergic to when you're going into the hospital for a CT scan, right? Like the reception person's going to ask you, and then the person taking you back, and then the nurse, and then the technician for the machine. I get it, because if you get the wrong medicine, it's going to be a problem. But what I don't get is, I've told you that I have diabetes mellitus type 2. Like, that's probably not going to change unless I get an operation or something else that's very unusual. And so please, let's just go with the assumption that I still have the diseases that I had on the problem list last time, and move from there. That's a much more meaningful experience for me. It's a much more meaningful experience for the physician, but they need the technology to support that, right? Just because you have an expensive EHR does not mean that you have a good experience, that all that information is easily at your fingertips. Oftentimes it's not. Sometimes that's the vendor's fault. Sometimes that's the hospital's fault, the way they've configured it. But if it's not made easy, then it's understandable why things break.
I gave a talk a couple of years ago, and one of the physicians came to up next to the stage afterwards, and she said, "Man, Mike, you have some really high expectations of us." I was like, "Yeah, because the stakes are too high. Like, your words carry, like, they weigh 100 pounds with me. You're probably the top 5 most influential voices in my life, behind my wife and kids, and dad and mom." And so, but at the same time, I've also now worked in healthcare nearly 25 years as just an observer, as a patient, and as a writer, and working in the concierge medicine space. But regardless, I've come to the conclusion that healthcare is always going to be a little bit convoluted, a little bit complicated, even for my kids and their kids. And there's reasons for that. And the push away from, well, let's go direct to consumer, let's eliminate, payers, relationships, and those types of things. You know, I have insurance. I think you may as well. Like, it serves a purpose. It's important, because I mean, yeah, it's incredibly complicated, and I'm the last Canadian on the planet to probably think that things like concierge medicine are kind of a neat thing. But streamlining efficiency, streamlining clinical workflows, that's going to go it's going to happen through automation and through technology. In your work in this space, now we're moving into AI to the rescue. What's your thoughts on this? Because this is a little bit of a scary thing for a lot of clinicians to think about. But I heard a marketing guy say the other day, he's like, I use it like it's an intern. And I thought that was a neat approach, but there's more to it than that, and it's getting more popular. Especially if you since you just wrote a book, Designing for Health, which we'll put in the show notes below, how to access that. You know, AI can really help us, but it can also maybe be a double-edged sword.
Yeah, I'm very excited about, I don't want to say specifically generative AI, not so much AI in general. A lot of people are saying, hey, this is just it's the beginning, and there's a lot of hype here. I don't know. I'll tell you something that I've done. I uploaded. Normally, I speak at conferences from time to time, and twice now I've said to a group of clinical folks, I've uploaded patient information to ChatGPT to see how it would manipulate that, and then there's a roar across the room because you're not supposed to do that. And I said, okay, calm down, calm down. The patient information was my information, and I'm allowed to put it out there if I want to. Darn it. And so I did. And so so here's the story. I uploaded an MRI. I had a MRI of my lumbar spine because I'm old, and that's what one does. One gets back pain, and at some point, after trying lots of different things, you get an MRI. And I got this report, and I am a licensed and board certified physician, and I had no clue what this thing said. And so I called up my friend, the radiologist, who was the best man at my wedding. And I said, hey, here's the report. I don't have the images, but just interpret this report for me, sell it to me as a primary care physician, explain it to me. And he did a great job at doing that. And then maybe a year or two later, ChatGPT came about. And I said, wonder what happens if I upload the same MRI report. So again, this is not images. These are just the interpretation of the radiologist. I took away my name, so that wasn't there. And I said, hey, here's a report. Please summarize this for the level of a primary care physician. And this is regular old ChatGPT that anyone can access, not made for healthcare, not in any way, added to. It did a great job of summarizing it, much like my friend, the radiologist, did. I said, that's interesting. Now summarize it for a patient with no medical, experience or knowledge. It did a great job. To your point, thinking of this thing as an intern right now is certainly the way to go. It's really good at summarizing information, but you can't use it exclusively because it's still going to miss information occasionally, right? So most of the time, it does a pretty good job of summarizing large amounts of information. Most of the time, it does a pretty good job of taking patient handout for maybe and say like, hey, I'd like this patient handout to be written for an 8th grader. And so how will you change it so that maybe some of the bigger words are made more simple? Maybe some of the examples are more up to date and relevant for a kid nowadays. Generative AI is really good at that kind of stuff. Where is it not so great? We still struggle to get an algorithm that will predict sepsis. We've been trying to predict which patients are most likely to have a code outside the ICU, which is something that we always like to avoid happening. Still struggle with those things. We make some improvements, but it's kind of like 2 steps forward, 1 step back. Oh, it worked at this hospital, but now when we take the exact same algorithm being fed the same information and pop it over to this other hospital, we don't really see any significant improvements over what a human could do. And so, AI, machine learning, it's helpful, but I don't think we're there yet. With generative AI, once we start to get some controls in there, to your point about the intern, and make it specific for industries like healthcare, how we're using it, it's going to be a big improvement. I think one of the examples that you can already see is almost all probably of the electronic health record vendors are leveraging generative AI to answer patient questions that they submit through the patient portal to the physician or to the care team. And so now with a lot of the EHRs, and still not everywhere, but it's a lot of places, you get a pre-canned answer. This is an answer that the AI has, with the information that it's given, has generated, and it thinks it's going to get you 80% of the way there. And your job as the physician, instead of looking at a blank note that you have to type a response in, hey, we've started it. Please just read it over, edit it in any way, and then send it. It's not as cool as it could be. And the reason is that they don't have access, that AI does not have access to the whole chart. Usually it only has access to a small number of things. And I've complained to one of my friendly EHR vendors about, like, hey, this still sounds very like 12th grade ish, like you're not really helping me here. And why is that? And he's like, hey, it's pretty complicated what we're trying to do, and we can only feed the AI so much information before it becomes just too expensive, too time consuming, can't respond. And so as that gets easier, you can feed it more information faster, less expensively, then the responses will get better and better. And that's just one little thing. Like, wouldn't it be great? Like when I practiced, I had a medical assistant that did this for me. When I walked into the room, a significant chunk of the time, most of the information I needed was already written down on the piece of paper. And half the time, my medical assistant or nurse would already have a patient handout because she diagnosed this child with croup or with strep throat, right? And I would walk in jokingly saying, like, hey, my medical assistant thinks your child has croup. I'm going to check everything because she's only right about 98% of the time. And that seemed real to me, that she was right. It seemed like, I never did a study, but it seemed like she was right most of the time because she knew what she knew and she knew what she didn't know. And so, she wasn't going to go looking in a child's ears with an otoscope, but she was going to look in their throat, right? With just have them take a quick look. And so oftentimes she would queue up for me either orders or patient handouts. That's where we're seeing generative AI be able to, I think, help. And this is not decades from now. This is years from now. This is happening today. And it's a young intern, and this intern will be very, very experienced in just a number of years, I think.
Oh yeah, and wait till it hits our mobile devices on a regular basis, where there's 3 or 4, big behemoth apps that we're going to start downloading. I remember just a few years ago, downloading an app, and then over a website internet connection, I uploaded securely my whole genome sequencing data to their stuff, and then I could play with my genetic data through this app store. It was called sequencing.com. It's still out there today. It's a really unique resource. But for example, there was a weather app, and it was super helpful to just play with. And so when we can, as patients, play with our data, it makes us a little more informed. We're not getting our information from some generic internet search anymore, but we're bringing in and maybe having a bit of more of an intelligent conversation with you. So we're not wasting your time, because we do know it's valuable. We do respect you. And we do know that, you've got other people. And, one of the questions that always hits curious physicians when they bump into concierge medicine is, well, that means they're going to be calling me all the time if I do this. And it's like, you talk to the concierge doctors out there, and they're actually like, no, you'd be surprised how little and infrequent I get those calls, because they are very respectful after 5 o'clock. Like they don't want to necessarily bother me when that's my family time and their family time.
Right.
But our guest is Dr. Joseph. Let's talk a little bit about what's happening at Nordic. What's your work over there? What is Nordic? And what's some of the stuff you guys have been working on?
Yeah. So we're a healthcare management consulting company. We've got about 3,000 consultants. So we're not huge, but we're not small either. And we help healthcare systems and hospitals and physician offices leverage, really at the core, leverage technology to help them do what they need to do. So we have folks who are really smart about clinical aspects, about operations, about revenue cycle, lots of different things that we focus on, but it's always with healthcare at the center. I like to say we're a healthcare company that happens to do management consulting, and so lots of different things. Started off really just focusing on electronic health records. We still do that, and sometimes we help clients who are just overwhelmed. They know how to do the thing, they know how to fix it, they just don't have the people right now, and they can't hire them fast enough. So we'll do that. Sometimes we'll go in and say hospital might say, hey, we have this problem, we don't really know why we're losing market share, we don't really understand, patients are complaining, or our doctors are very unhappy with our technology, and we think it's pretty good and it benchmarks okay, and we don't understand why. Sometimes that's the technology and you need to fix it. Sometimes it's, oh, well, these physicians that are very unhappy actually don't have the administrative support. They don't have an MA or a nurse at the right levels, or it's very interesting. This clinic where everyone's upset with the electronic health record, turns out that they're one of the main clinics in a system for training medical assistants. And so those medical assistants are constantly churning through. And I think for physicians, we understand what a medical student is versus a resident. I once my first day of third year of medical school, I was doing general surgery, and I asked the wizened old senior surgical resident if I could help him. And he wasn't the nicest guy, but he was very honest. And he said, "You want to help me? Don't help me." Right. And again, I don't recommend that attitude, but I understand it. And his point was, once I actually train you up to make you actually helpful to me, you're going to be moving on to the next rotation. And so that's just the way it is. Same with medical assistants. And so I've certainly found with one client, the problem was the medical assistants were being trained up and then moved out. Well, that's very beneficial to them and to the office that they're going to, but the physicians never at that office really never got a chance to kind of have a mind meld with their MAs or nurses or other support staff, and hence didn't really get benefits that everyone else got. Not a technology problem, an operations problem, a personnel problem. And so kind of using your diagnostic skills to solve these is fun. And I think that kind of describes what we do.
Are we going to find that technology in healthcare, in a doctor's office, in a pediatrician's office, is going to, I mean, a lot of office managers, office administrators, those who are not necessarily wearing a clinical or provider hat, they're resistant to it because they know it's going to put them out of it. Like, it's going to take away part of their job or all of their job. So what type of resistance are you meeting when you have those types of conversations related to integrating technology that is, going to be helpful, but also how to do it the right way that, yeah, I mean, you're not replaceable, but at the same time,
we're all replaceable. Yeah. I heard I've actually heard multiple people say that artificial intelligence or AI is not going to take your job. Someone who knows how to use AI is going to take your job. And I would say the same thing to those folks that you're describing, like, hey, it's highly unlikely actually that any technology can do the job of the office manager. That's someone who makes the place run. And AI will never be able to call up a receptionist who's having trouble making it to work on time and trying to understand why that is. They're not going to be able to AI is not going to calm down an upset patient because you're running late. There are things that we need humans to do. And so I'd say my suggestion is, hey, you need to be as up to date and leverage all the tools that are available to help you with parts of your job that you don't actually need to do. So if you're making the schedule for the physicians for an on-call schedule, for example, there's pretty good technology that does that now, that knows that Dr. Smith doesn't like to be on Fridays, but really doesn't mind Saturdays and Sundays, and that Dr. Jones is taking vacation during this month. Like, all of that information is that trying to kind of come up with a sweet schedule. That is not something that a human should be doing now. And so, your job is not at risk unless you don't acknowledge that there are tools out there and that you're not using them, right? So I think all of us would much rather have humans be doing things that only humans can do, and let the technology or other processes, automation, take care of stuff that we don't need to do. And so I think that we're not going to see wholesale firing of folks. We are going to see people spending their time doing smarter things, right? There's no reason for a medical assistant to go in and ask all these questions when the patient already answered them. That medical assistant can do lots of other things that bring more value to the patient, more value to the clinic or hospital, by doing things that only humans can do, kind of looking them in the eye and making sure that the information is correct, understanding that when, looking at the body language and highlighting that for the physician that's about to walk into the room so they understand. Those are things that are not going to be replaced, I would argue, by technology. And so just understand what's out there, understand what you don't need to be doing. And if there's a computer program or technology that does it better than you, then get it and work on other things that only you can do.
Our guest today is Dr. Craig Joseph, and he is with Nordic, as well as an author. He recently wrote a book that we'll put in the show notes below. It's called Designing for Health. And now we move on to the lightning round of a couple of questions. You can be however long-winded or brief as you would like to. These are questions we pretty much ask of every doctor who comes on. But you had one on a recent podcast, and I thought this is a great question to insert into a lightning round. Should patients be charged for messages to their doctors?
So yes and no. Patients should absolutely be charged for messages to their doctors that would have replaced an in-person or a telehealth visit, right? So if you're going to go back and forth or answer questions as if they were in the office, or you were doing a virtual visit, then I would fully expect to pay for that, because in the past the answer would be, if there was no patient portal for us to have these conversations back and forth, the answer would be, I need you to come in and we can talk about that. Mm-hmm. So if you don't want to come in and talk about that, and we can do this asynchronously, either back and forth or do it some way like that, then yeah, I fully expect that you should be willing to pay for that. What you shouldn't expect to be paying for, things that you typically could handle over the phone in the before times, before we had these ubiquitous electronic health records, right? So, I just had a billing question. I forgot. Can you add this allergy to my medication, to my list of allergies? Something that's really short. Hey, do you think I need to? I had this thing. Should I go see the gastroenterologist? Like yes or no type stuff. No, I don't think that's appropriate to pay a copay for, because the physician's spending hardly any time responding. However, if you said, hey, this thing happened, should I go see the gastroenterologist? And I'm like, okay, I'm not sure. Let me go check. Let me look through your chart. Let me remind myself of what's going on. Let me go look and see what the gastroenterologist said last time. Okay, now that's taken 5-10 minutes. Yeah, well, guess what? Now I would expect that to have to pay for that. And so it's a little bit disconcerting, because the patient doesn't know, I don't know, when I send off that message, is this going to be something that I have a copay for or not? I get that. And that's suboptimal. And I wish it weren't that way, but that's the way we pay for healthcare. Much in the same way, when you go to the doctor, or you go to the hospital, like, it's nice to know what the charges are going to be beforehand, but we all know that's not, I can't predict that often, right? Is that going to be a 99213 or a 99214? How much information am I going to need? How much work am I going to have to do? We can't predict that ahead of time. So sometimes the charge is going to be variable. So that was a long-winded answer to sometimes. That's a short-winded answer.
Oh,
Sometimes.
I think as a patient from my side of the exam room, as a patient, most of us as patients, if I went to the bus stop and talked with the moms group at the bus stop, they wouldn't have any clue as to where can I even find a doctor that would communicate over a secure platform like that. I mean, you're telling me that that's an option? Like I don't have to go, I can just get some simple questions answered. And that's where technology is going to come in, and further adoption is going to play a role. And I did an experiment of my own, like similar to you uploading your stuff to AI. I did an experiment where I counted the last 2 or 3 years of text messages with inside of the secure app, because I just wanted to know how many times did the doctor get involved and how many times did the office managers or whoever else is working there that day get involved. And I would say it was probably 70 to 60% of what I was throwing out there was handled by anybody else but the doctor. And I
Yeah.
appreciated that because I was like, because I felt as though like I don't want to text them like I got the colonoscopy results, but I feel like that's just something that anybody can handle. But this is the one device app that he told me to use, so I'm using it. Um, and so it was a unique experiment, and to know that we are making progress, moving closer to a deeper connection with our physician, a more informed patient, but also a more engaged and happier, hopefully, physician as well. Because we want technology to make physicians a little happier. That leads us to our second question of the lightning round, and that is, what was the last thank you note you sent or received?
Wow. Well, I sent a thank you note today. Now this was via email. I didn't handwrite it. Does that count?
I'm a big handwriting guy, but I'll take it.
Okay. All right. Um, I sent a thank you note to someone. I was at a conference last week, and this person had invited me to a lunch. And there were a bunch of very interesting people there who I'd never met before. And it was not only was there food, which was great, but there's a great crowd, and learned some stuff and met some new people. So yeah, I sent that thank you out. Curious though, I'll throw a question back to you if I'm allowed. Yeah, actually, I'm going to do it even if I'm not allowed to. Um, there are a lot of hospitals now that are suppressing thank you messages to physicians via the patient portal with the rationale. And these thank yous are coming from two sources. One, from patients who just say thanks. That's the message. Thanks. And two, from nurses. Hey, would you go check on the patient in 423A? The heart rate's been high and I'm concerned. And then the doc says, yep, I'll be there in an hour. And the nurse says, thanks. And you think that, oh, these are just niceties. We should be doing these things. However, if you're in the hospital making rounds and you get a secure message, you must stop what you're doing and look at it. And it might just mean looking at your watch and seeing the word thanks, but it also might be pulling out your phone, and that 10 seconds or 5 seconds is taking you off what you were doing beforehand. And so I'm glad you didn't ask me about that, because I don't know how I feel. Like at one point, from one perspective, I really like knowing that the nurse said thank you and acknowledged, the work that I'm doing, and the patient as well. But on the other hand, I'm like, yeah, but I could use the 15 seconds of not being distracted.
Yeah, yeah. It's almost you could see as a tech person, similar to like your default or the conversation you mentioned earlier, you could see that being fixed somewhere, like a tone. Like we get notifications, like if it's a certain ringtone or a certain beep or whatever, that's acknowledgement of this phrase. And you could kind of see that could maybe be helpful. That would, like, okay, I don't have to reach my pocket or my belt to grab it.
Yeah.
Where we could see these things being tweaked and fixed. And was it, as I was writing another chapter of the book we were talking about earlier, is you have a unique place as a physician in everybody's lives, that you're solving my problem now, but it's just going to create another problem for you to solve later. So it's like, yeah, I'm healthy now, but now I'm taking in too much protein, or I'm taking in too much of this or that. But it's so I just want to say thank you for your work. And yes, I do accept electronic thank yous as an answer for that. I have an entire tote at my house of just thank yous from doctors that are electronic paper, that I save, not for the fact that I'm going to go back and read them. It's just, in fact, I've even put a note as we updated our legacy documents. I said, you can shred them, burn them. I don't care what you do with the tote, but for now, I want to keep the tote, just because it's a reminder that I made a dent in the universe. We can't change healthcare, but we can make a dent in, make it a little bit better than how it found us. And that leads to our last question for you. And that is, it's a bit of a two-part question. It's half testimonial, but it's also, well, you're an example of, we say this a lot, it's no longer about being the best doctor in the world anymore. It's about being the best doctor for the world, and for your patients, and for your local community, and for wherever you are, And I always am just so, I feel like I have some days the happiest job in the world, because I get to work with happy doctors and talk to happy doctors. And that's not always the case, but the immense pressure that's on you and your peers' shoulders, but yet you willingly, shoulder that burden every single day. And then for those that are running, into the penalty box again on Monday, and they get what we call, what some call out there, the Sunday scaries, that anxiety before work the next day. I just want to say thank you to all the doctors out there. I know when I found for my kids, we finally found, after searching, doctors after doctors visits, waiting room after waiting room, finally found the right orthopedic surgeon for our kids, for my daughter's scoliosis, which was pretty severe, and my son's couple of different surgeries when he just simply fell out of a car on vacation. It's like, goodness. We finally found him, and it's just like, goodness, I have such immense respect for the responsibility you guys have. And I know that you guys enter it and you're so compassionate and giving. And so thank you so much for your time today, and for the work that you do in business and in technology and in healthcare. And I don't think that you have bad breath today, but I have heard my daughter say some of those very direct things to her doctor, and it just makes us laugh. So thank you again for your time. And we'll put the links of how to get access to Designing for Health in the show notes below, as well as links to Nordic as well, and how to connect with Dr. Joseph. Thank you again for your time today.
Thanks. It's been a pleasure.